Now we have 90 participants.
Okay.
So now we can start our ORS Week Activity 2020 IAP Trivandrum in association with Trained Nurses Association of India, Kerala State Branch, Zoom orientation class for nurses. Over to you, sir. Bennet, sir.
Okay.
President, IAP Trivandrum.
Very warm welcome to IAP Trivandrum. Respected our State President, Dr. M. Narayanan, our State Secretary, Dr. Balachander, TNAI State President, Dr. Sona, TNAI State Secretary, Biju SV, our President Nominee, Dr. Riaz, our Secretary, Dr. Priya, Dr. Amit, all the dignitaries who are attending our Zoom meeting. My dear friends, you all know that today is our ORS day. We are fortunate to have you also with us for this get together and Zoom meeting for a discussion about ORS, because you all know that ORS is the wonder drug, especially in the last century. And we are fortunate to have this drug at least from 1964 onwards as ORT, which is turned to be a ORS in after 90, 80, 90 and all. From 2001 and 2004, we changed over to low osmolar ORS. Presently, it is called as the standard ORS of World Health Organization. And basically, to give the more importance more and more, we are conducting, especially IAP, conducting the program of ORS Week and ORS Day every year from 23 to July 23 to July 29 as ORS Week and 29 as ORS Day. Lot of people were died because of cholera and similar illnesses due to dehydration, but because of the invention of ORS, we could control this death, especially due to diarrheal diseases. As you all know that one of the major causes for the death in India, even now, is diarrhea, especially outside Kerala. We are fortunate to have a good system in Kerala in the medical care. And even now, because of the COVID season, we know that this problem is there. And even for COVID, the ORS is the better drug of choice for children especially, because one of the common symptom with the COVID is diarrhea and dehydration. And and along with this, we could conduct a lot of program, especially in community level, with the public awareness program. As I being a president of IAP Trivandrum, wrote an article in IMA, Nammude Arogyam magazine, in the July edition about the ORS, and we could make a video from Trivandrum, participated with 30 doctors about the ORS, especially our senior most faculties from our medical colleges and the junior most pediatricians from our state. And we could conduct inaugural session of ORS Week, and another program we conducted was Anganwadi workers training program. It reached more than 55,000 Anganwadi workers, and it was inaugurated by our beloved Biju sir IAS, who is the Women and Child Development Secretary. And the doctors program also separately conducted, and today is the final program of this ORS day and week. Now let me go to my own job, that is welcoming all. First, instead of busy schedule, Dr. Narayan, he is always there with us. And for this meeting, when I told him, he said, definitely I will join. Today also he got three more program. Because of this virtual platform, we got him for this. And Thank you, sir, and welcoming you for this Zoom meeting. Second, Dr. Sonam, our state president, TNAI. When I contacted Madam through one of my friend, Nidish, who is our staff nurse in my hospital, and without any second thing, she said we can do the program. And actually, for any program, a cooperation is required between organizations, and we could achieve that. Achieving is done only because the interest has to be there for the leaders. That is there with IAP and our TNAI organization. And thank you, madam, and welcoming you for this Zoom meeting. Next is our state secretary, Dr. Balachander. He is always there with us, always welcoming any program which is in Trivandrum, and his support is always there with us. I am welcoming you, sir, for this meeting. Then Biju SV, who is also a state secretary, I couldn't contact him before, but welcome you, sir, for felicitation address with our meeting. And actually it is not, and they are the makers of IAP Trivandrum, our state president nominee, Dr. Riaz, our own secretary. She is making everything and arranging everything. And Dr. Amit, who is the person who is giving, is a very famous doctor in Andrukonam or hospital health service, but practically he got an expertise in technical aspect also, along with our Dr. Praveen. And I welcome you, all of you, to this meeting. And the most important thing is, without any participation, there is nothing like a meeting. So I'm welcoming all the members who are attending in this Zoom meeting for IAP Trivandrum and TNAI of Kerala. Thank you. And over to Narayan, sir.
Now let me invite Dr. Narayanan M, President, IAP Kerala, for his presidential address. Over to you, sir. Please unmute.
Good afternoon to you all. President Dr. Bennet, NAA President Dr. Sona, Secretary Mr. Biju, IAP Trivandrum Secretary Dr. Priya, Dr. Riaz, and my dear colleagues in IAP and delegates. It's a great occasion for IAP Kerala to join you in this platform, where a major organization, Trained Nurses Association of Kerala, which I'm told has a strength of over 80,000 members, is joining IAP on the day of World ORS Day, an important day where we give awareness to the public regarding the importance of ORS. So, you know, because all the professionals joining this Zoom meeting, you are all aware of the importance, the role of ORS in reducing mortality in children. If you take the statistics, you know that under 5 mortality in India has come down from 2.5 million in 2001 to 1.5 million in the year 2012. And this is due to interventions like diarrhea treatment program using oral rehydration therapy, immunization, then ART control programs, all those programs. Still, diarrhea continues to be the third most important cause of mortality in under 5 children. The story in our state is different. Our health statistics are much better. Our literacy is better. Our awareness on ORT and other interventions are far ahead when compared to other states in Kerala. But if you know the details of the knowledge of regarding ORS in mothers, it is said that 73% of the mothers know about ORS, the role of ORS in diarrhea, its importance in reducing the mortality in diarrhea. So 73% know about that. Whereas when it comes to the usage of ORS, only 43% of the mothers in India use ORS. So between this 73% and 43%, there's a large gap. That gap is called knowledge gap. We know something, but we are not using it. That is the gap, knowledge gap. So this year, our attempt, especially the doctors, the nurses, and other hospital staff, all healthcare workers, our aim should be to reduce this knowledge gap, which means we should encourage mothers to use ORS whenever there is diarrhea. So that's one request I have to make to you all who are attending this Zoom conference. Secondly, my congratulations to all branches in Kerala, especially the Trivandrum branch, because the Kerala State branch inaugurated the ORS Week with the Trivandrum branch, and all these 7 days, it was on 23 of this month. Now today is 29th. 7 days have passed. On all these days, Trivandrum branch has been doing a variety of programs. It was classes to or training programs to doctors, nurses, Anganwadi workers, and they have prepared video. So, and through the AR media and also through the print media, this sort of awareness programs conducted by Trivandrum will definitely help to create more awareness in the public on ORS. Today we have an excellent faculty in the form of Dr. Riaz, who is a president's nominee of IAP Kerala, who is an additional professor at SAT Hospital, Trivandrum Medical College. He will be detailing about oral rehydration therapy to you all, and definitely that will be an asset to your knowledge. So I wish this Zoom conference all success, and especially thank the Trained Nurses Association for joining hands up with us in this noble endeavor. Thank you.
Thank you, sir. And for the felicitations, let me invite Dr. Balachandran, Secretary, IAP Kerala. Please unmute, sir.
Thank you, Dr. Priya. I'm extremely happy and thankful to IAP Trivandrum and TNAI Kerala State Branch for inviting me to illustrate this august audience. I had a good time with the TNAI. Excuse me? I had a good time with the TNAI. Video? Video it's on. Okay.
Okay, no problem.
I can see your screen. Else on the screen.
Can't see, sir.
Okay.
It's okay with your
Okay,
audio.
the message.
Okay, sir.
Volume, നമ്മുടെ നെറ്റ്വർക്ക് കുറവാണെങ്കിൽ ചിലപ്പോൾ വീഡിയോ മൂവ് ചെയ്യത്തില്ല. അത് കുഴപ്പമില്ല. Continue.
Maybe. Yeah, maybe. So I got a good association with the TNAI 5 years back when we got a training at TNAI headquarters Delhi. When we were trained for skill lab training as part of RMNCH plus health services. And we are trained by 2 doctors as well as 2 MSc nurses. So our association in the Academy of Pediatrics is this year we have built a Down syndrome day from March 21st to community. It is child and adults that ORS Week celebration we do the last week of July with including July 29th, which is compulsory as ORS Day. And today is the state validatory function of ORS Week. We started these activities from 2001, I think, and a lot of messages has been conveyed to the doctors as well as the nurses as well as the agents and body workers and all. Maybe that is why we don't see much dehydration cases now. Of course, there will be some dehydration and now dehydration, but severe dehydration cases are very less, especially now. And this program, IAP Trivandrum organizing, they have done a lot of activities this week. And not only Trivandrum, all over the state, many branches has done. But because of this COVID, we were limited to virtual meetings. But we have done exhibitions as well as poster exhibitions as well as classes to the doctors, nurses in the respective hospitals. So I take this opportunity to congratulate IAP Trivandrum and TNAI associating for organizing this ORS program for the nurses who are the very important part of the team which convey messages to the public. So I wish this program all the best. Thank you. Jai Hind, Jai IAP.
Thank you, sir. Now let me invite Dr. Sona PS, President TNAI Kerala, for her felicitations. Please unmute, madam.
Yes, thank you, Priya ma'am. Good afternoon, all of you. And we all know that we are sailing through a very tough situation of fighting with COVID-19 pandemic. And actually, we have almost adjusted to learn to live with the coronavirus. And even though we cannot meet in person, we are utilizing other online platforms to celebrate such international events. So today we are celebrating this World ORS Day. And as experts say, ORS is the health drink or the one right solution for managing acute diarrheal diseases for all age groups, from newborn to very old people. So I believe nurses have a very good role in disseminating information about this oral rehydration therapy and the solution to the public at large. So I am very happy that IAP is associating with our organization TNAI for such webinars, and I expect such future associations also. And I wish all the success for the program, and reminding everyone to keep social distancing and to do hand washing frequently to fight coronavirus. So thank you all.
Thank you, Dr. Sona. Now it gives us immense pleasure to get associated with TNAI to organize ORS Day program of 2020, as we believe that it is a collective responsibility to disseminate knowledge related to ORS. I wish the program all success. I am happy to announce the winners of the poster competition, which IAP Trivandrum did with GNC, with Government Nursing College Trivandrum. I thank Dr. Binsi, Principal GNC Trivandrum, and Dr. Prevalata, HOD Pediatric Nursing, for their support. I also thank the coordinator, Dr. Preeta, Assistant Professor of Pediatric Nursing and NSS Program Officer, GNC Trivandrum. We have selected the best 2 entries. I shall share the best 2 entries. I hope it is visible.
Back, one slide back. Yes.
Is it visible?
Now it is visible.
Okay, so these are the 2 best posters. All entries were very good. I appreciate the efforts of all the participants. Please continue the good work. These best entries, Vishnu Priya and Adarsh V, They'll receive a cash prize and IAP immunization guidebook as gifts from our side. We have also prepared a GIF, which all entries are included, and it will be circulated in our WhatsApp. Thank you. And now let me invite Dr. Riaz, Associate Professor of Pediatrics, Government Medical College Trivandrum, and State President's nominee, IAP Kerala, for his class. Dr. Riaz, please unmute.
One second, see, we will be having a certificate. It will be, it is there in the link. Actually, after the final program, it will be published.
Full screen, Akamo.
So I bring greetings from SIT Hospital Trivandrum and IAP Trivandrum. So at the outset, I wish to thank Bennet sir, Priya and Praveen for giving me this opportunity of teaching and learning. And also I extend first actually IAP's congratulations to the nurses of our country for leading the fight. Actually, you are in the forefront rather than we are. And I wish continued support as well as best wishes, and we shall definitely overcome this pandemic. And I have seen that there are friends joined from other states also. So when we say about diarrhea and ORS, always or sometimes at least we take it as a very mundane subject, because what is much about ORS or what is much about diarrhea? It's a very simple thing. But when we look at the figures, we can say that 5.3 million deaths occur in the under 5 age group in the world. And in 1990, it was 12.6. So over the years, the survival of children are becoming better. And look at this particular figure. See, these deaths, over half of all the deaths which occur in the world among children occur in India, Nigeria, Afghanistan, Pakistan, and Ethiopia. And mind you, with our population, almost 1/3 of all these deaths are occurring in our country. And what are the causes of mortality in under 5 children? They are preterm birth complications, pneumonia, birth asphyxia, congenital anomalies, diarrhea, and malaria. Look at the list. If you want to bring down mortality due to congenital anomalies, fatal congenital anomalies, it is almost not possible. The only way out is you have to do an antenatal scan at a time when a medical termination of pregnancy is possible, and not allow the child to be born. And about prematurity care, it is a very high investment area. To make a newborn preterm survey, like a 800 grammer or 500 gram survey, we know the effort as well as the cost. Birth asphyxia is something we always tell about, and we train ourselves to prevent that. But there is a significant amount of birth asphyxia which occur in utero where we cannot do much. Then it boils down to the areas which can have intervention, mainly pneumonia and diarrhea. Interventions means low cost interventions. And diarrhea is one such area. And still, diarrhea is the cause of around 14% of deaths in our country. So what are the interventions we can have? As medical personnels, we always say about ORS, we always say about prevention by giving breastfeeding and things like that. But there are a lot more interventions which the administrators can do, like providing safe drinking water and improving the general health as well as the socio-economic conditions of the people. So having said that, this is just to impress upon all of you. Diarrhea is one of the leading causes of death still in our country, and there is a lot for us to do. This is actually from our HOD, previous HOD, Dr. Sulekha Madam. I think at least a few of you also may be knowing her. She was our professor and HOD in SIT hospital for a long time. And this was a diarrhea treatment and training unit project she did during 1989 and 94. And you can see the case fatality has plummeted like a rocket, and it has reached almost zero in the five-year period. Can anybody guess what has happened or what has changed? The same hospital, the same team. What was changed was the modality of treatment. For a long time, all of us believed, or the scientific world believed, treating diarrhea is by IV fluids as well as antibiotics. So there were children admitted in large wards in hospitals all across the country, where children with diarrhea stay for weeks getting IV fluids and multiple antibiotics, and most of them succumbed to either dehydration or infections or starvation or malnutrition. So here what changed is the wonder drug which is called ORS, or oral rehydration solution. That is why we say ORS is the actual health drink. We all see lot many advertisements telling that this is the health drink which can help your child to grow, help your child to become smart, help your child to survive smarter, healthier, like that. But in diarrhea, there is only one health drink, and it is oral rehydration solution. The only intervention which made this grand reduction in case fatality is the introduction of ORS. The method of treating diarrhea with IV fluids was stopped. Irrational use of antibiotics were stopped, and the children were treated according to the state of dehydration using ORS, and the situation improved. Even the admissions became less. And at least my colleagues who are here in the nursing college now know that the diarrhea ward which we were having is now being used for treating other children, because there is no child to be kept in diarrhea ward. We have a small room in another ward where we keep diarrhea children, because admissions had come down to that extent because of diarrhea. And all the change has happened with the help of ORS. And this has not happened only in Kerala, it has happened all over the country and in the world as well. So what I'm going to do in the next 10-15 minutes is I will discuss a small points which all of us know, but we may be not very sure about something, and we will have a discussion where Dr. Priya and Dr. Bennet sir will be joining us. And most of these slides, the courtesy is to Dr. Priya Sreenivasan. So how do you define acute diarrhea? Diarrhea is loose stools less than 14 days. And we should know that usually diarrhea will settle down within a period of 7 days. You treat or not, the loose stools will end in a period of 1 week usually. And what is the definition of diarrhea? WHO defines diarrhea as loose stools, at least more than 3 watery stools in a day, or there is a recent change in the consistency and frequency of stooling in a child. So the same disease is called acute diarrheal disease, acute diarrheal disorder, or acute watery diarrhea. So all these are same. It is acute diarrhea. And we should know what is dysentery. Dysentery means there is presence of visible blood and pus in loose stools with abdominal pain and fever. Here, the inevitable thing is visible blood in stools. So, if somebody had tested the stool in a lab and are telling that there are RBCs in the stool, it doesn't qualify for a definition of dysentery. Dysentery in our Malayalam local term, it is called vairagadi. Here, there will be visible blood, and distinguishing between acute watery diarrhea and dysentery is important because dysentery indicates it is due to the infection of a bacteria which will need antibiotic therapy. So, always look for and ask for the presence of blood in stools. Then, having told about acute diarrhea, there is something called persistent diarrhea. When we are telling acute diarrhea is up to 14 days, persistent diarrhea is more than 14 days. And what is the worry? What is worrying us when the diarrhea is persisting? Because when the diarrhea is persisting, there is a chance the child can die because of the pre-existing malnutrition getting aggravated, and the child is starving, the child is not getting its nourishment, the infection which can progress to sepsis, all those things. I have told you in the beginning that usually acute diarrhea settles by 1 week. So the between period, that is 1 week to 14 days, you call it prolonged diarrhea. So acute diarrhea, the upper limit is 14 days, but remember, usually it will settle down by a week's time. If it is going beyond 1 week, up to 2 weeks, you can call it prolonged diarrhea, where you will think about, or you will be starting to worry about something serious which is happening in the child like that. And if it crosses that 14-day period, then it is persistent diarrhea, which needs your immediate attention because it has a more case fatality rate than an acute diarrhea. And remember, out of all the diarrheal deaths, 50% of them occurs when the child passes on to the persistent diarrhea stage. So that is the importance of identifying a child with persistent diarrhea. We are discussing all this in an elaborate manner because, you know, in this pandemic period, all healthcare personnels, be it a doctor or a nurse educator or a faculty in a college, either medical or nursing, all of us should refresh our knowledge in common diseases because people are unable to reach hospitals, people are unable to take the child to a pediatrician. So we should be helping out on all these conditions. So what is the consequence of diarrhea? I told you diarrhea is a disease which causes eventually death in children. So acute watery diarrhea will cause dehydration. It will perpetuate malnutrition, eventually causing death. Dysentery or bloody diarrhea, usually the infection can become very severe. It can affect the brain, sometimes causing encephalitis, Shigella encephalitis. There can be sepsis, then malnutrition, and that can also lead to death. Persistent diarrhea, again, malnutrition and death. And the recurrent diarrhea, when the child is getting multiple episodes of diarrhea and other infections, what will happen is the child will go in for severe acute malnutrition, where the immunity is also broken down and the child develops severe systemic infections, sometimes heart failure, and even death. So these are the things, or these are the organisms which cause diarrhea in children. We need to remember a few. One is the rotavirus. We know most of our diarrhea, maybe around 90% or more of our kids who are coming with diarrhea are suffering from rotaviral diarrhea. And we know that the country had started giving rotaviral vaccination, and it has reached Kerala also last year. But also remember, there is something called enterotoxigenic E. coli, which is almost similar to rotaviral diarrhea. Both of these will start with high-grade fever, then vomiting, and then explosive diarrhea. It will be very watery diarrhea causing dehydration. Usually, there will not be much of cramps or anything, not many other extra-intestinal symptoms, but vomiting and watery loose stools with a very high purge rate. We should also remember, or we should not forget, a few other things like Shigella, because Shigella is one other organism which is a bacteria which can cause explosive diarrhea, because the onset is very dramatic. The child will develop high-grade fever, and the more pronounced thing will be blood in stools and cramps and the high-grade fever which persists. The rotaviral diarrhea, even if it starts with high-grade fever, it will settle down soon. But Shigella, the fever will persist. There will be cramps, severe abdominal pain, and systemic manifestation. The child will be appearing very sick. Sometimes there can be changes in the mental status also. The child can be drowsy, the child can have seizures. All these things are important. And another thing is, you should also remember that endamoeba or amoebic dysentery is very, very rare in children. As healthcare personnel, we should all know that we need not give Metrogyl or anti-amoebic drugs to every other child who is developing a diarrhea, because endamoeba as a cause for diarrhea is very rare in children. It can happen in adults mostly. So regarding the most important cause, which is the rotavirus, it has an incubation period of less than 48 hours, usually affects this age group of children, that is 3 months to 2 years of time. Usually the virus destroys the tip of the villi, and which causes the loss of the enzymes there, which helps in absorption of your disaccharides. And what will happen is these disaccharides just remain in the lumen, which will invade water coming out of the intestine, and which will ultimately cause loss of a lot of amount of water, which leads to dehydration. So this can cause severe dehydrating diarrhea. So out of all the deaths due to diarrhea, 28% is because of rotaviral diarrhea. I told you 50% of deaths occur due to persistent diarrhea. So remember, 28% is because of the rotaviral diarrhea. Fever and vomiting, I told you it settles down very soon. And if the high-grade fever persists, always think about a bacterial cause like Shigella and blood in stools also. So these are some very unlikely or rare causes of diarrhea in children. Remember, most of these occur when you have a party or a festival where a food poisoning has happened. Always remember about Staph aureus and Bacillus cereus. The presentation will be very dramatic. They have taken part of a common meal, and the next day or within hours of exposure, they come with common symptoms like vomiting and diarrhea. And Giardia, Cryptosporidium, all are very rare actually, not very common in our children. And this is one slide I want all of you, sorry, all of us actually, to imprint in our heart. Because identifying a child with dehydration is the most important thing a person who is treating diarrhea should know. Because if you miss this chance, if you miss the chance of identifying dehydration, there is high likelihood the child will go for complications and a possibility of losing that child. So it's very easy. The WHO has devised a very easy method to assess dehydration, and it is called the look and feel method. Just look and feel. You are supposed to look at the condition of the child, whether the child is active, alert, talking with you. So if the child is active, alert, talking with you, that means the child is having no dehydration. There is no dehydration at all. A child who is having some dehydration will be restless, irritable. The child will be irritable, and the child will be may not be very happy looking child. The child is irritated. A child who is not able to speak, who is unable to speak, who is not interacting with the mother, or who is drowsy or unconscious, it means there is severe dehydration. So severe dehydration, lethargic or unconscious, means it is an emergency. It is a red channel. You have to act immediately, as soon as possible. Look at the eyes. If the eyes are sunken, that means there is dehydration. It is not very easy to classify between some or severe, but look at the eyes. If they are sunken, that means the child is dehydrated. Regarding the thirst, a child who is not thirsty, you are giving ORS, the child is telling, okay, I'm okay, I'm not very thirsty, then it is no dehydration. A child who is asking you for ORS, a child who accepts ORS readily, we know that ORS doesn't have a very good taste. So if a child accepts ORS readily, who takes ORS readily, then the child is having some dehydration. A severe dehydration child won't be able to drink because the sensorium is not good. The child is drowsy, the child is sleeping. So that means it is a severe dehydration. Also look at the skin pinch. Skin pinch I will show you. So this is how you look for the skin pinch. So just take a pinch of skin on the side of your umbilicus in the longitudinal way, not in the transverse way. And if it goes back, it should go back in a flash. You are not, you will not see it going back. When you just remove the fingers, it will be like it was before. It was in the same plane. Then it means there is no dehydration. Or if you can see it going back, if you can see it going back, that is, it goes back slowly. If only it goes back slowly, you will see it. That means there is some dehydration. And it is remaining like that. You had pinched and that pinch is remaining like that. It is not going back. It is going back very slowly. That means it is severe dehydration. So using our look and feel method, we can very easily diagnose which child is having no dehydration, who is having some, and who is having severe dehydration. The child who is having no dehydration can definitely go home, but we will give some advices and a packet of our magic drug ORS. The child who is having some dehydration should remain with us. We have to supervise the recovery, but the only treatment which we are going to give the child is ORS, continued with a close watch on the child. And when the child is having severe dehydration, it's an emergency, all the red flag is up, you have to get an IV access in this child. You have to get an access, be it an IV. If you don't get an IV access, you go for an intraosseous access, because this is the child who can develop cardiac arrest, who can develop shock, whom we can lose at any time. So severe dehydration is always an emergency. So also look at something else other than dehydration, and that is malnutrition. Because out of 100 children who die because of diarrhea, 70 of them will be having associated malnutrition. So, if you have a child who is having no malnutrition with severe dehydration, you are a little more maybe uh, complacent. So otherwise, if the child is having any sign of malnutrition, always be on your toes, because this is the child whom you are going to lose. So if it is persistent, if it is severe, if there are frequent episodes, all the more reason the child may die. And the problem is there is no use of looking at the eyes, because due to malnutrition, the eyes will be sunken. There is no use looking at the skin turgor. The child will be having loose skin folds all over the body. You cannot assess dehydration looking at the skin turgor. The oral mucosa as well as the eyes will be dry because of the malnutrition, because the lacrimal gland as well as the salivary gland will be atrophic. There will not be any tears or saliva coming out, and the tongue will also be dry and bald. So the only signs which remain useful in children with diarrhea dehydration who are having severe acute malnutrition are, one is thirst. So if a child is thirsty, some child who is thirsty is having some dehydration. Look at the urine output. If the urine output is less in a child with diarrhea, that means the child is having severe dehydration. And also look for the pulse volume and rate, because we can identify shock. Even though we cannot identify the what you call dehydration, we can definitely identify shock. See, all these doesn't need any extra skill. We day in and day out look at all these things. We always ask our parents, do you drink? Are you thirsty? We always measure our patient's urine output, and we always record the pulse rate and volume. So if there is tachycardia, if the volume of the pulse is becoming less, that means this child is having severe dehydration. You have to act. So don't look at the appearance, because appearance will be misleading. And a word about our wonder drug ORS, or oral rehydration solution. I think students will know the difference between what is ORT and ORS. ORS means oral rehydration therapy, while the solution which we use for ORT, for oral rehydration therapy, is called ORS, or oral rehydration solution. And we have a homemade, easily available, or ubiquitous ORS, which is called ORT, because ORS is the name only for that synthetic powder we get. Everything else is an ORT. So SSS means salt sugar solution. Salt sugar solution. So you take maybe 6 spoons and 6 spoons of sugar with 1 spoon of these are teaspoons, I'm telling, teaspoon of salt mixed in 1 liter makes an ORT for a patient who doesn't have an ORS at home. And there are a lot of food-based solutions. That is our what you call that uppitta kanji vellam, or rice water with salt, or lassi with salt, or dal water with salt. All these are home available fluids, home available ORTs. But you can even use coconut water. You can even use lemon juice with a little salt. But never use your that slide is missing. Never use drinks like tea or coffee as ORS, because they are drinks which we use in very small quantities. You cannot rehydrate anyone with that. It doesn't have any salt. It may be having sugar, but it doesn't have any sodium. And the whole principle of using ORT or ORS is we are transporting sodium ions along with glucose across the intestinal wall. This is the intestinal lumen. You are drinking ORS and this sodium and glucose using the gate called a sodium glucose co-transporter is getting inside our interstitium, from where it goes to the intravascular compartment, thus rehydrating our body. So when glucose and sodium comes together, water also gets in. Water also gets back to the body. That is how rehydration occurs. So we need both sodium and glucose, and that again in a particular combination. Then only it helps. This is about something about our old story. Because once ORS was discovered, we know that ORS was discovered at a time there were a lot of cases of cholera. And cholera, we know, is a rapidly dehydrating disease, and there is a lot of loss of sodium ions. So cholera stool, 1 liter is actually 101 milliequivalents. So at that time, the WHO ORS, which was called the classical ORS, had 90 milliequivalents of sodium to match the loss of sodium in the cholera stool. Later, it was found when the number of cases of cholera came down, and the most common reason for diarrhea and dehydration in the world became rotaviral diarrhea, there was not much of sodium loss. And to that effect, the children were receiving a little more amount of sodium when the children were given ORS, resulting in a mild puffiness of eyes on treatment with ORS. The WHO changed to reduce this electrolyte imbalance. And now the new WHO ORS, which all of us use, which is available in the government setup, which is available as the WHO ORS formula in all our medical shops, it is sodium is 75 and glucose is 75. That is iso-osmolar composition. And that is only needed because non-cholera stool in diarrhea has only a sodium loss of 56. So that is why we have reduced the sodium content. And this is the one all of us have. I think this will be very familiar to all of you. It has around 23 grams of ORS powder in one pouch, and that is to be added to 1 liter of water. They don't say it should be boiled and cooled water or anything. You can use any potable water, any drinking water, even mineral water or from a tap or whatever the family is drinking, because we cannot ask the mother to boil and cool every time when the child has a diarrhea. So this ORS offers no risk of hypernatremia. It promotes water and sodium absorption more efficiently because it is an iso-osmolar ORS. The osmolarity is 245. The initial classical ORS was having an osmolarity of 311. So it reduces stool output by 20% and also reduces vomiting by 30%. As the sodium content decreases, the chance of vomiting also decreases. And there is less chance of recurrent dehydration and reduces need for supplemental IV fluid by 1/3. So plan A is for children who are having signs of no dehydration. We have to tell them that there is no need of dehydration, but we should prevent dehydration from happening at home. We should not allow the child to go for malnutrition. We have to do something to reduce the severity and frequency of the diarrhea. So what we advise them, we give them either ORS or a home available fluid with salt or any other type of ORT, and always tell them not to give a lot of tea or coffee. And during diarrhea, the child should not be starved. They should be given the normal food what the child is taking, because the absorption is okay. See, around 95% of carbohydrate you eat will be getting absorbed during diarrhea. 75% of proteins will be getting absorbed. Nobody is going to take any fat during diarrhea, but that also if you eat, it will get absorbed. So nothing to worry. So tell the mother that you can feed the child normally. And one or two tips we should remember is, if the mother is giving a lot of fruits, ask her not to, because these fruits have a lot of sucrose, and this sucrose will produce fructose molecules, a lot of fructose moieties in the intestine, which will cause osmotic diarrhea. So no to lot of fruits. If the mother wants to use any fruit, we can ask them to give boiled bananas, because banana has a lot of potassium, as well as there is some pectin in that banana cover, which can also help in hardening the stool. So otherwise, we can give all the food. And if the child is on a lot of cow's milk or anything, we have to reduce that. But you should encourage breastfeeding when the child is having diarrhea. You are giving ORS. Along with ORS, we can give breastfeed also, especially so in a child who is less than 6 months. Less than 6 months, ORS should be alternated with breastfeed. So after that, this is also very important. Once the child had recovered, one extra meal, like if the child was taking 3 meals in a day, make it 4, because the lost calories we have to make up. That is why one extra meal for 2 weeks, that is one supplementary meal. And if the child is malnourished, you have to continue that extra meal till the child recovers. That's what. Then zinc is actually a boon for all of us, because when we give ORS, the parents are not happy. You are just asking us to give some powder and mixed with water. It is just water. We need some medicine. So now we have a medicine which can be given, and it is zinc. Zinc usually comes as solutions or powders to be constituted into suspensions, or even tablets are available with the RCH kit. And it has a very important role in actually re-epithelializing the what you call the intestine. That is very important, because once the epithelium gets regenerated, the lactose intolerance goes away. It replenishes the border, or replenishes the immunity, and it can regulate the water and electrolyte absorption, as well as optimize appetite. So zinc should be given for 2 weeks duration. It is not that once the dehydration is corrected, or once the diarrhea is over, you can stop zinc. Zinc should be continued till 14 days, so that it prevents recurrent diarrhea also. So when you are sending a child home, we have to clearly tell the mother when to return. What are the red flag signs? The child is passing many watery stools. The mother is not able to replenish what is being lost. So it is a large volume, many stools. So then it is difficult for her, so ask her to come back. Because of repeated vomiting, the child is not able to retain ORS. Come back. If the child is very thirsty, whatever ORS you are giving, the child is not getting satiated, then you have to come back. Or if the child is not taking ORS, or if child develops high-grade fever, there is blood in stool, or if the child is not getting better within a period of 72 hours, you should ask the mother to come back for a review, because all these may indicate bacterial infection, sepsis, complications of diarrhea like electrolyte imbalances appearing. So you have to admit the child and observe. So plan B means when the child is having some dehydration, it is again ORS at the quantity of 75 ml per kg. And I want all of my friends to learn this. We learn as 75 ml per kg. And if you try to tell this to the mother, it is actually futile. Never tell a mother you have to give 75 ml per kg, or you give 1500 ml, 1600 ml. It is not useful at all. We have to calculate what is the amount of ORS to be given, and tell the mother in next 1 hour, you give these many glasses of ORS, or these many ounces of ORS, something like that. Because this ML thing is not at all understandable by the mother. And at the end of 1 hour, you have to reassess the child, because 4 hour correction doesn't mean the child will improve in a normal path. In between, the child may have a very hyper stool, and the child can go for severe dehydration. So every half to 1 hour, any child who is having some dehydration in our observation room, we have to go and look at her or him and see what is the state of rehydration, and then change our plan accordingly. If there are some puffy eyelids, that means the ORS we are giving a little excess. So in small infants, to prevent this, always alternate with breast milk. Sometimes in older child also we may have to plain water. And always make sure the child is taking the daily requirements, and also correcting the ongoing loss. That is very important, because over and above this 75 ml per kg, you have to ask the mother to give the or to correct the ongoing loss. Like we know, when a 6 months to 1 year old child is having a loose stool, we will ask them to give half a glass of ORS. So it is from 1 year to 5 year, we will ask them to give one glass of ORS. And if it is more than 5 years, we will ask them to give, with each loose stool, you give as many as ORS, as much amount as ORS the child needs. So that is how you may. And older child, always give plain water, food also. And if there is some dehydration, you have to repeat that and send home only after feeding the child. These are some conditions which I have already explained. High purge rate, if the stool rate is very high, persistent vomiting, abdominal distension, all these things, we will need the stoppage of ORT, and we may have to give some IV fluid. These are very, very rare instances, but be in the lookout for that. 99.9% of children in the plan B or with some dehydration will definitely improve with your ORS alone. Plan C, I have already told you, it is like a cardiac arrest situation. At any time, the child can go in for a requiring resuscitation. So you put in a line, be it an IV line or a intraosseous line, and start with a IV fluid. Most of the time, we start with normal saline, even though the WHO says ringer lactate with 5% dextrose, which is not available easily in our part. Usually, what we use is normal saline. Ringer lactate also can be used. And if you are not getting an IV access and you are not able to do an intraosseous, the best next thing we can do is put in a nasogastric tube and give 20 ml per kg per hour of ORS. Here it is not normal saline or ringer lactate, it is ORS, and refer the child. It is not like you are going to keep that child for next 6 hours. You have to refer, because in a higher center, someone will take access. And the duration of treatment of ORS is the dose for rehydration, severe dehydration is 100 ml per kg, where you divide it into 2 allocotes, 30 plus 70, for less than 12 months. That is, in an infant, the 30 ml per kg allocote is given in the first hour, and the rest is given in next 5 hours. It becomes a little more faster if the child is more than 1 year. And this is very important. I told you, you have to reassess a child who is having some dehydration every half an hour. Here, we have to literally sit with the child, and every 10 minutes or 15 minutes, we have to make sure that the pulse is improving. When you are rehydrating a child with IV fluid or the intraosseous rehydration, what will happen is, as the child is getting rehydrated, the pulse volume will improve and the pulse rate will come down. If the pulse rate is not coming down, if the pulse volume is not improving, that means you are losing the child. So that is the time you have to think about other measures to act. So are there any other drug which is useful in the treatment of diarrhea? It is actually a no, but there are a few drugs which can help you sometimes. They only have some adjunct role. They are not drugs meant for diarrhea, but it can help you sometimes. One is a anti-vomiting drug, because if you have an antiemetic, If when a child is having persistent diarrhea, you can give that and you can continue the ORT. That is one thing. And these probiotic drugs are useful when there is an antibiotic induced diarrhea. When you have fever, you have to think about dysentery and other co-infections, some infection somewhere. If the fever is persisting, I told you, rotaviral diarrhea within 1 or 2 days, it should go away. If it is not going away, you have to think about other causes of fever, like a pneumonia, like a urinary tract infection, like a ear infection, like a meningitis, and things like that. So this is something very, very important, because when we are telling about ORS, when we are telling about diarrhea, you should start every time with exclusive breastfeeding, because this is one intervention which has clearly shown that there is decrease in diarrheal morbidity as well as mortality. So 6 months of exclusive breastfeeding. And also, if you continue breastfeeding along with complementary feeds, there is the but this preventive effect can continue. So that is important. And also remember, the preventive effect of breastfeeding is most marked in lower socioeconomic class, where the children can get more episodes of diarrhea, as well as their resource limited settings, and can have morbidity. So breastfeeding is all very much important. Regarding hand washing, the interventions which promote hand washing clearly show a reduction in diarrheal risk. This is actually evident now, because I think all of you who are working in hospitals will agree with me. The diarrheal admissions had come down. Why? Why? Because everybody is sanitizing the hand, everybody is doing proper hand washing, so diarrhea had come down. And also eating out has come down. So it is very, very important. But the sustainability, we don't know. Once the corona is over, we are not very sure whether our people will continue to hand wash. So there are some vaccines also. I will stop with this. And Rotacil is the vaccine which is available in our state from the National Immunity Schedule. The dose is 2.5 ml. We give along with the primary vaccines, that is the pentavalent 1, 2, and 3. Along with OPV we give. It is an oral vaccine, but the amount is a little more, 2.5 ml. And there is no need of any booster. We have to complete the vaccination within 1 year of life. That is very important. And I think with that, okay, measles vaccination. Always promote measles vaccination, not only rotavirus vaccine. Measles is one disease which can predispose the child to diarrhea. So always prevent measles to prevent diarrhea. And I don't think these are very important. Then, okay. So ORS is definitely a relief for all of us, because this is again from Sulega Madam. See, in 1989, in the ward 4, which was the diarrhea ward, they had used 12,000 bottles of IV fluids. Okay. And in 1994, that is after 6 years, 5 years, what has happened is it is only 300. So for us, actually, the burden has decreased, because putting up IV cannulas and IV fluids has come down. So at that happy note, I stop and I'm ready for questions. And for question answer session, I invite Dr. Bennet Xylem, who is our president, as well as a community pediatrician who had done a lot of work in diarrhea management, and he is also manning a coastal hospital. And also Dr. Priya Sreenivasan, who is our secretary, and also who is doing some research in rotavirus vaccine. Thank you. Thank you.
Thank you, Dr. Riaz, for that wonderful session. Now we'll have the discussion. Actually, we do not have much questions in the chat box.
One question was there about the rotavirus vaccine. Can they give after 1 year? But it's not recommended. It is recommended only up to 1 year only, as per government guidelines. Earlier, we were given this medicine, this vaccination up to 6 months only. Now it is changed. The present policy is up to 1 year. And one more point is, if somebody has taken vaccination, let it be any other vaccination, once they have taken, then you are not supposed to give the rotavirus vaccine as a next dose, because because of some logistic problem. It is not otherwise. Scientifically speaking, you can give rotavirus vaccine up to 1 year of age.
As there are no questions, let me ask some questions, Bennet sir. Can you use the ORS if the packet is hardened? Suppose the contents inside it is hardened. Can we use it?
Actually, it's a good question. And last during the when we took the class for Anganwadi workers, the same question was asked, that can we use the ORS solution when it is hard or when it is liquid? Because if it is hard or if it is a liquid, then you are not supposed to use it. The reason is, in ORS, the water is a drug. For any other medication, we know that, like suppose if you are giving an antibiotic, nothing harm in giving if you are putting more water in it. But for an ORS, it is an equilibrium dose has to be there. It's a proper proportion has to be there. So you are not supposed to use little powder and little water like that. Similar way, if it is solidified, you are not supposed to use it. Or even if it is liquefied, still you are not supposed to use it. It has to be a powder.
Okay, thank you, sir. Another question is, which syrup is used for zinc supplement?
Zinc supplement, actually you can use it any syrup. Government recommendation is tablet, because practically government supply is there. The point is, it's not the question of syrup or drops or tablet. It is a question is, for 2 months to 6 months, it is 10 milligram per day for 14 days. For 6 months to 15 years, it is 20 milligram per day for 14 days. After 15 years also, you can give it, no harm in it, but recommendation is up to 15 years.
Okay. Another question is ORS recommended for newborns?
Definitely, ORS is the only drug which is recommended for newborn, other than vitamins, and especially we are supplementing with this vitamin D3 as a routine. Suppose a child is having any medical problem, drugs are recommended, whatever may be the condition of the child, including hypothyroidism, like our endocrinologist, Dr. Riaz is an endocrinologist, he will be able to tell better about the thyroid problem. Anyway, for any thyroid problem, you can give drugs. But as far as ORS is concerned, if the child is having diarrheal disease, and if it is a watery diarrhea, you are definitely supposed to give ORS, because the plasma level of our electrolytes also is same like in ORS. So better you give ORS for even for newborns.
This question must have come because we tell till 6 months it is exclusive breastfeeding. Now, what is the definition of exclusive breastfeeding? Exclusive breastfeeding means you breastfeed the baby. It is only breast milk, nothing else, not even water, except in certain situations where you may have to give ORS or some nutritional supplements. So that is the definition of exclusive breastfeeding. So if needed, you may have to give ORS, and there is nothing wrong in giving ORS even to a newborn, and you have to continue breastfeeding also. In plan C, is potassium chloride added to normal saline? See, in plan C, the idea is to rehydrate the baby. So you rehydrate the baby, that is, the baby is in severe dehydration. So you correct the dehydration using that treatment plan C. That is, if it is for a baby within 1 year of age, you have to correct it within 6 hours. And after, if the baby is after 1 year, that is post infancy, means you can correct it within 6 hours. So that is the dictum. And you should see whether the child is passing urine. Now, once the baby has passed urine in the maintenance fluid, that is after 6 hours, you can, if in the maintenance fluid, if you are putting, you can put potassium chloride. And the dose is like in 1 pint or 500 ml, you can add 5 ml of potassium chloride. But you should see to it that child has passed urine.
Okay, one question is why zinc is given for 2 weeks? Zinc is given for 2 weeks. That is the recommended doses. This is after the proper research and studies. It will prevent. It will improve the intestinal integrity. Basically, there is a derangement in the intestinal epithelium when child is having a diarrheal disease. That will get corrected with the zinc supplementation. The evidences are saying that it will decrease the stool output during diarrheal disease, and recurrence also it will prevent. That is the advantage of giving zinc.
Okay,
Is
sir.
there any evidence that rotavirus prevent diarrheal disease? Next question.
What question, sir?
Is there any evidence that rotavirus prevent diarrheal diseases?
The question is about the efficacy of the vaccine.
Okay, it is. See, the vaccine is very effective only for rotavirus. Diarrhea, you can get it to any other organism. Like already Dr. Priya said, bacteria, fungus, virus, anything can cause diarrheal diseases. Rotavirus vaccination is given only for preventing rotaviral diarrhea. That is common. That is the reason we introduced the rotavirus vaccination in government plan. And it will causes the diarrheal diseases with the excoriation, perianal excoriation. That will get prevented. It is common in less than 1 year of age. That is the reason we started rotavirus vaccination.
Okay. And Archana Gopinath has asked, there is a wide practice of giving black tea with lemon to children with diarrhea. We have to discourage it while educating public. Sure, we have to discourage usage of black tea with lemon.
The baby, next question is, the baby is irritated and not taking breastfeed, and what will be the management?
It's a very practical question. It is not only regarding the breast milk. All of us have kids, and we all may have tried of giving ORS to our children. It is not very easy. Even ORS or breast milk, whatever. But we have to make some conclusions from the behavior of the baby. Like when a child is thirsty, that is when a child is having some dehydration, the child will take. So your child is not taking, and the child is active, and the child is pushing away the ORS, or for the matter breast, that mean that the child is not having dehydration. Okay, that is something we can be we can get from that. And if the child is not feeding, that means the child is not interacting with you, the child appears sleepy, and the child is not taking, that means it is not the time you continue with either breastfeeding or ORS. It is the time you have to reach the hospital to manage as pregnancy. Okay, that is how you have to manage.
One good
And
question
if the baby is irritated, if the baby is irritated for a long time and the baby is not taking breastfeeds at all, then it can be even some condition like some dreadful condition like meningitis. So if this situation is continuing, means again you should meet a doctor.
Yes.
One more question is there, hypertonic solution like 5% dextrose is suitable. Actually, 5% dextrose solution is practically not a hypertonic solution, because once it reaches the liver, that will be you metabolized immediately, and practically what you get is hypotonic solution, not the hypertonic solution. Ideal solution for diarrhea management is ringer lactate with the 5% dextrose. Practically, ringer lactate with the 5% dextrose is not commercially available. That is the reason we can give ringer lactate or normal saline. It is not 5% dextrose. 5% dextrose is practically is a hypotonic solution. So it is not recommended.
Another question is, a baby has got severe thirst and is continuously drinking ORS. Can we put IV line along with ORS? Actually, the child is continuously drinking ORS, which means that the child is not in severe dehydration. If the baby is in severe dehydration, the baby will be so lethargic that the baby will not be able to drink ORS continuously and vigorously as you are telling. So this is not severe dehydration, and this may be some dehydration. And if you feel that there is no, the dehydration is not that prominent, but the child is having severe thirst, means it will be some other complication like hypernatremia. So in that situation, it is better that you look for sodium levels as well.
Next interesting question is, fruits are rich with fibers, whether it helps to control diarrhea. Actually, fruits, if you are giving a lot of fruits, it is a lot of fibers are there, but practically normal use of fruits will not affect, increases the diarrheal diseases. Of course, even for a banana, like yathapalam, it is good for diarrheal diseases. Already, I think Riaz already mentioned about it during his class. And like Palayangudam palam, that may be a little laxative. So some bananas are there which is it has got a laxative effect. Overall, saying normal fruit juice is not it will not cause much laxative effect. But if you use sugar more, like if you are taking a fruit juice from the shop, what they put is a lot of sugar will be there. So once the hypertonic solution, so the fruit juice with the sugar is a hypertonic solution to the gut. What will happen is it will absorb water from the body towards the intestine, and again the purge rate will increases. That is a problem. That is one another reason is in uppitta kanjivallam, like rice water, it's a light rice water, you should use it. If you use a thick rice water, what will happen? The same problem will happen. One more point is, a lot of mothers they give glucose water. Again, the glucose water, the problem is the glucose concentration in the gut will increases, and that will absorb water from the body, and purge rate will again increases. So these are all not recommended. But for a normal fruit juice without sugar, all can be given as household ORT, not ORS.
There was a question that whether Singovit can be used instead of zinc syrup. We cannot use Singovit because Singovit contains a very small amount of zinc. It is not in the recommended in the dose recommended for diarrhea, and it also has some other ingredients which may exacerbate diarrhea. So Singovit is not the syrup which we use. We should either use, as Benessa told, the tablet which is available, or the powder, the dry powder which we can make into a suspension, or even zinc syrup, plain zinc syrup is also available.
Okay. And now it is already 4:30 p.m. I think we can stop the discussion for this time. Okay.
Yes.
And let me invite for the vote of thanks, Biju sir.
Okay. Thank you, Dr. Priya. Good evening, everyone. It gives me great pleasure in proposing the vote of thanks. It was a very informative session for nurses on the occasion of the ORS Day 2020. First of all, I like to thank Dr. Narayanan, President IAP Kerala, for delivering the presidential address and for being the backbone of this program. Thank you, sir. Next, I want to express my gratitude to Dr. Riaz, Associate Professor of Pediatrics, Government Medical College, Trivandrum. It was an excellent session, sir, highly informative, and also raised some nostalgic memories about the SAT hospital. Thank you very much, sir. Thank you for sparing your valuable time in between your busy schedule. Now, I like to thank Dr. Bennet Xylem, President IAP Trivandrum, for welcoming all. Thank you, sir. I would like to thank Dr. Balachander, Secretary IAP Kerala, Dr. Sona PS, President TNAI Kerala, Dr. Priya Sreenivasan, Secretary IAP Trivandrum, for offering their felicitations for this orientation class. Thank you all. And also Dr. Amit Kumar for his technical support. Thank you, sir. And I would also like to thank Nitish for connecting TNAI. And my thanks also go to all the participants of this class for taking your time out to be with us. And many of our faculty and students are on online classes. They will be joining our YouTube channel later. Hope all have enjoyed the session. Thank you all. Once again, thanks to everyone. Thank you.
Thank you, Mr. Biju. And those who have missed the session, as he has already told, you can go to the YouTube link, IAP Trivandrum YouTube channel, and kindly subscribe our channel also.
One more point, and for e-certificate is there already made by our TNAI State President Sona Madam, and I think maybe because of Biju sir also, and the link is already there. It is already there in the chat box. You can take a photograph now itself and apply for it, and it will be available. Because it is our YouTube is it's a public property and it is published always. So we are not showing that in the YouTube link which is coming next. So you have to take a photograph of this. And it is very, thank you for all be with us for this good afternoon and good evening.
Thank you, sir.
നമുക്ക് ഇന്നും മീറ്റ് ചെയ്യാം അല്ലേ? Okay, breastfeeding also we will meet. Thank you, Riaz. Bye.
I don't think we can leave now, sir. Sir, photo എടുക്കാൻ പറഞ്ഞുകൊണ്ട് ഇനി എല്ലാവരും ഫോട്ടോ എടുക്കുമായിരിക്കും ചാറ്റ് ബോക്സിൽ.
എല്ലാവരും ഒന്ന് വീഡിയോ ഓൺ ചെയ്തിട്ടേ നമ്മുടെ ഈ if everybody can just open your video so we can get the photograph of the grid.
Okay, that will be
that
excellent idea.
You can share with both the organizations, TNAI as well as IAP.
Please open your, please do that.
Yes, that will be helpful to give
the video on ചെയ്യണേ.
certificates തരാനും presents അറിയിക്കാനും.
പ്രിയ ഫോട്ടോ എടുക്കുന്നുണ്ടോ?
ഞാൻ എടുക്കുവാണ്.
പ്രിയ എടുത്തായിരുന്നോ ഫോട്ടോ?
ഞാൻ എടുക്കാൻ പോകുന്നു സാറേ.
Print screen
actually it is nice to see faces of people without mask now, because we are unable to see the faces otherwise.
പലരെയും familiar ആണ്.
ഫേസസ് കാണുമ്പോൾ സന്തോഷം തോന്നുന്നല്ലേ നമ്മൾ പുറത്തിറങ്ങുമ്പോ.
നിതീഷ് 2 വാക്ക് സംസാരിക്കുന്നു. ഞങ്ങളുടെ സ്റ്റാഫ് നഴ്സ് ആണ് നിതീഷ് ഭയങ്കര അക്കാഡമിക് ആക്ടിവിറ്റീസ് ഒക്കെ ചെയ്യുന്നതാണ്. നിതീഷാണ് നമുക്കിങ്ങനെ ഒരു ലിങ്ക് ഉണ്ടാക്കിയത്. എന്തായാലും നിതീഷ്
സാർ താങ്ക് യു സാർ. എനിവേ ഒരു എന്താ പറയുന്നത് സാർ, ഇങ്ങനെ ഒരു അക്കാഡമിക് ലിങ്കേജ് ഉണ്ടാവുന്നത് എസ്പെഷ്യലി 2 പ്രൊഫഷണൽ അസോസിയേഷൻസ് തമ്മിൽ വളരെ വലിയൊരു കാര്യമാണ്. കാരണം ഒരു ഷെയറിംഗ് ഓഫ് നോളജ്, അത് മാത്രമല്ല ഷെയറിംഗ് ഓഫ് തോട്ട്സ്, ഒരു വലിയൊരു തരത്തിലുള്ള ബ്രെയിൻ സ്റ്റോമിംഗ് നടക്കുന്നൊരു സെഷൻസുകളിൽ ഒന്നാണ് പലപ്പോഴും ഇങ്ങനെയുള്ള പ്രൊഫഷണൽ അസോസിയേഷൻസ് തമ്മിൽ ഇന്റഗ്രേറ്റ് ചെയ്യുക എന്ന് പറയുന്നത്. എനിക്ക് വലിയ സന്തോഷം സാർ. താങ്ക് യു സാർ. ആൻഡ് TNAI ഒഫീഷ്യൽസ്, സോന മാഡം, ബിജു സാർ, താങ്ക് യു.